Hello and welcome to Health Professional Radio. I'm your host, Neal Howard. Glad that you could join us. Our guest is returning to speak with us, Dr. N. Lawrence Edwards. He's a rheumatologist, and he's here to discuss with us some new gout research and also to talk about why medical professionals should adhere to the American College of Rheumatology, or ACR, guidelines, as opposed to the American College of Physicians, or ACP, guidelines. These guidelines apparently conflict, and Dr. Edwards is here to clear the air for us. Welcome back to Health Professional Radio, Dr. Edwards.
Thank you, Neal. It's a pleasure being with you.
When you were here before, we talked about a little bit about gout. For our listeners who may be unfamiliar, talk about exactly what gout is and what are some of the symptoms to look for.
Sure, Neal. Gout's the most common inflammatory arthritis that there is. So you hear a lot on TV about rheumatoid arthritis and psoriatic arthritis, but gout is at least 4 and maybe 5 times more common than either one of those forms of arthritis. And it afflicts about 9 million people in this country. It can be a devastating and destructive form of arthritis, so that over years, not only do people have the types of symptoms that everybody thinks about with gout, which is extremely painful, abruptly swollen joints, like their great toe or their ankle or their knee, that leaves the person immobilized for 3 or 4 days. But it's really can progress on to where they have destruction of the joints and pain every day, and it can lead to difficulty just carrying out activities of daily living.
Now, you talked about how widespread gout is. A survey last year suggested that most of us don't even understand gout. You explained the basics to us just a minute ago, but patients who are diagnosed with gout remain, less than vigilant in taking the right steps to manage their gout. Why do you think that is?
I think most of this comes down to education, Neal. I think that physicians are very busy in their office. I don't think patients are told the simple basics of the disease process, that they have. Gout's a chronic disease caused by elevated uric acids in the blood. Now, most people with gout view the disease as being something that they've brought on themselves. So they've heard this for a long time, maybe even in their family, people that have gout, that the myth is that they have the disease because they overindulged too much of one type of food or the other, too much drink. And because of that, they're somewhat embarrassed to have the disease. But the truth is that it's a metabolic condition, and most of the predisposition to having gout is inherited, so that the high uric acid level is something that they have throughout their adult life. And it simply needs treatment like any other chronic disease, like diabetes or hypertension or high cholesterol. The gout is the clinical manifestation, and people focus on that, but it's a disease that's always there, not just when those flares are occurring.
Now, if we're going to shed some light on gout, how can we be as effective as possible when you have differing opinions as to its treatment and its management? Talk about some of these conflicting guidelines between the ACR and the ACP when it comes to gout and uric acid.
Sure, Neal. I should say right off that I'm a member of both of those organizations. I'm a master of the American College of Physicians and a master of the American College of Rheumatology, and considered an international gout expert. The gout guidelines that were offered by the American College of Rheumatology are very similar to the guidelines that came out from the similar group in Europe, as well as the British Rheumatology Society. In that there was a recommendation that all people with gout, after they've had their first or second flare, should have their uric acid lowered by medication until the serum uric acid level is less than 5 or 6 milligrams per deciliter, which would put it in the normal range. And that's essentially internationally accepted as a treatment standard, and we now call that a treat-to-target sort of mode. And we pick that number because we know if uric acid is lowered to this level, that over time the accumulation of uric acid around the body will dissolve, and the number of flares that a person has will gradually dissipate until they no longer have any gout flares. Now, remember that they still have a metabolic disease that's going to cause uric acid to go up if they're not taking medication to draw it down. And so the recommendation is that they get on a uric acid lowering therapy and they continue to take it lifelong. The American College of Physicians recently came out and said that the data to support this approach that's accepted, again, internationally, was circumstantial, that it didn't have a high level of research integrity, but I think that they missed the boat there, that it would be very difficult to do long-term studies with these drugs just because the drugs are so poorly taken. There's plenty of data to underpin the recommendations from the American College of Rheumatology, and I believe that the treat-to-target approach that those guidelines endorse are the correct ones. The alternative approach, which is what the American College of Physicians discusses, is a treat to avoid symptoms, which is just looking at the very superficial veneer of gout and not recognizing that consequences of not lowering the uric acid will ultimately result in a destructive, irreversibly destructive form of arthritis and disability.
In your opinion, do you think that some of this conflict between the guidelines of the ACP and the ACR, being a member of both of those organizations, do you see a resolution prior to the launch of the Gout Specialist Network, or is this anticipated launch of this network going to facilitate a better dialogue between professionals in both of these organizations to kind of get everybody on the same page?
Well, I think that there's ample evidence, and since the American College of Physicians guidelines have come out, there's been a number of editorials and discussion groups about just where that society's guidelines went wrong. Mm-hmm. There are excellent ongoing studies to answer all the questions about uric acid lowering, whole population studies going on currently in New Zealand, also in Japan, where it's not only do all patients with gout get put on uric acid lowering therapy, and we can observe those people over a year to see how much better they do than in the prior thought process where that wasn't happening. But even if you have an elevated uric acid and no gout symptoms, it has become the established approach in Japan to go ahead and treat with uric acid lowering therapy. So we're going to get a whole lot of data over the next several years from those large population studies to quell any rebuttal to the ACR guidelines.
Would you like to see an adherence to the one policy and an abandoning of the other, or would you rather see a merging of the two, streamlining the two into one policy that works well across the board?
Well, the ACP guidelines do have some good parts to it, and I should say that they endorse, as the ACR guidelines do, important recommendations about educating the patients so that they understand the disease, understand the medications that they're being placed on and what they do. I think that that's the answer to most all the problems in treating gout, is understanding by the patients of what's going on. To that end, we at the Gout and Uric Acid Education Society have set out to establish the Gout Specialist Network. You mentioned that before, Neal, and it's our new brainchild this year, where we'll really identify both generalists as well as specialists around the country who have an interest in gout, like to treat people with gout, take the time to explain to their patients what the disease process is and how to monitor it. And then we'll make that data available on our website at the Gout Society at gouteducation.org. The reason we're doing this is that we get called many, many times a week on our website asking for help, that they have a physician that seems to be ignoring their gout and not doing anything about it, and yet they are hearing that more should be done. And so we're trying to help them by identifying people maybe in their environment that would have some special expertise for this disease.
Well, I'm certainly appreciative that you could come in again and speak with us, Doctor.
It's always fun, Neal. Glad to be here.
You've been listening to Health Professional Radio, this Health Supplier segment, with Dr. N. Lawrence Edwards, rheumatologist, discussing some new gout research. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. You can subscribe to this podcast on iTunes, listen in, and download on SoundCloud.